Hello, everybody. I welcome you all to today's class, which is on hip joint pain and evaluation. Hip joint pain is a very important pain generator in our body, and it's very essential to identify the different causes which will lead to hip pain. And hence, today's class, we have Dr. Tejaswini Rao, who is currently doing her fellowship in pain medicine with us for 1 year, and she will be presenting on this topic. You can start off, Tejas.
Good afternoon, sir, and my fellow colleagues. I'm Dr. Tejaswini. I'm FIPM Fellow at Algos Multi-Speciality Pain Clinic. Today, my topic of discussion is about hip joint pain and evaluation. A quick overview about the presentation today. We'll start with the relevant anatomy, history taking, clinical examination, differential diagnosis, investigations, pain interventions, take-home message. Let's start with the anatomy of hip joint. So hip joint is a ball and socket joint which is formed by the articulation of the femoral head in the pelvic acetabulum. The acetabular labrum is the fibrocartilaginous rim, increasing the joint depth and providing the suction steel. Capsular ligaments, there are three ligaments around the hip joint. One is the iliofemoral ligament, which is also known as the Y ligament of Bigelow, which is actually preventing from overextension. Pubofemoral ligament, which is preventing from the over abduction, and ischiofemoral ligament that prevents from over internal rotation. Articular cartilage, it's the hyaline cartilage that covers the load-bearing surfaces. As a pain specialist, we should note that labral pathology and synovitis are the key nociceptive drivers in intra-articular pain. Sensory innovation, neural targets. Understanding the capsule sensory supply is vital for diagnostic blocks and radio frequency ablation. Femoral nerve, which is coming from the posterior rami L2, L3, L4, the articular branches supply the anterior and lateral capsule. Obturator nerve, anterior rami L2, L3, L4, the articular branches supply the anterior and medial capsule. Nerve to quadratus femoris supplies the posterior inferior capsule, and superior gluteal nerve supplies the posterior superior capsule. Nociceptor density is highest in the anterosuperior region. Lumbar plexus. So the muscular innervation of the anterior thigh is mostly supplied by the femoral nerve, that is the posterior rami L2, L3, L4. The muscles that are getting supplied by femoral nerve are the iliacus, sartorius, rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, and a part goes to pectineus and adductor brevis. Whereas the muscular innervation of the medial thigh is by the obturator nerve, which is from the anterior rami L2, L3, L4. It supplies the pectineus, adductor brevis, adductor longus, gracilis, adductor magnus, obturator externis. The cutaneous innervation is done by the lateral femoral cutaneous nerve on the lateral side of the thigh. And a few branches of our obturator nerve and the femoral nerve are covered onto the medial side of the thigh and also around the knee joint. Pain mapping and referred pain. Hip pain rarely presents in isolation. Identifying true hip pain requires differentiating from spinal or myofascial sources. So, when the patient comes with classic groin pain, mostly it is specific for intra-articular pathology. So, we have to think about osteoarthritis and labral tear. When the patient comes with C sign, that means patient cups his hand over the greater trochanter, pointing to deep joint pain. So, we have to think about femoroacetabular impingement. Knee referral. Since the articular branches of the femoral or the obturator nerves also supply the knee according to the Hilton's law, there can be little referred pain to the knee joint due to the hip joint pain. The muscles that can cause hip pain are ilias, psoas, gluteus medius, piriformis, tensor fasciae lata, and quadratus lumborum. Iliacus, the common referred pain location is front hip, groin, and the lower abdomen, and the most common cause of pain is prolonged sitting and poor posture. Psoas, lower back, groin, and front thigh are the common referred pain location, and the most common cause is due to core weakness or tight hip flexures. Gluteus medius, the most common pain location is outer hip, lower back, and outer thigh. The common cause is pelvic instability and muscle weakness. Piriformis, the common referred pain location is buttock and down the back of your leg, that is sciatica like pain. It is caused due to overuse, sitting for long hours at a time. Tensor fasciae lata, the location is lateral hip, IT band, and outer knee, and the common cause of pain is overuse in runners, poor gait mechanics. Quadratus lumborum, the common location is outer hip and lower back, whereas the common cause is side-lying posture and tight lower back. Let's start with the clinical history taking. Taking a thorough clinical history of hip joint pain is crucial because hip pain can originate from the true hip joint, the surrounding soft tissues, the lumbar spine, or the sacroiliac joints. Here is a detailed structure approach to taking a comprehensive clinical history for a patient presenting with hip pain. Let's start with the patient diagnostics, demographics. Age, certain conditions have strong age associations, that is developmental dysplasia or septic arthritis in infants, Perthes disease in young children, slipped capital femoral epiphysis in adolescents, femoroacetabular impingement in young adults, osteoarthritis or fractures in older adults. Sex, it's important because some conditions are very common in males, that is Perthes, ankylosing spondylosis, whereas females, they have more common prevalence of osteoporosis related fractures, developmental dysplasia of the hip. Occupation, heavy labor, repetitive lifting, or prolonged standing can contribute to joint wear and tear. Chief complaint. We have to record the patient's primary issue in their own words along with the duration. For example, pain in the right groin for the last 6 months. History of present illness, the use of Socrates mnemonic to comprehensively evaluate the pain. Socrates S stands for ask the patient to point with one finger to where it hurts the most. If the patient says groin or anterior thigh, it is highly indicative of true hip joint, that is intra-articular pathology. Lateral hip, that is the greater trochanter, often indicates the trochanteric bursitis or gluteal tendinopathy. Buttock or posterior hip often referred pain from this lumbar spine, sacroiliac joint, or piriformis syndrome. Onset. We have to ask, did it start suddenly? If it starts suddenly, it can be due to trauma, fracture, or acute infection. Or if it is starting gradually, that is generally seen in osteoarthritis and tendinopathy. Ask the patient, was there a specific inciting event or injury? Then C in Socrates stands for character. Ask the patient if the pain is sharp, dull, aching, throbbing, or burning. Generally, burning or tingling like sensation is seen in neuropathic causes like sciatica or meralgia paresthetica. Radiation. Ask the patient if the pain is radiating down to the front of the thigh to the knee. Commonly seen in the true hip osteoarthritis. Does it shoot down the back of the leg past the knee? It suggests the lumbar radiculopathy or sciatica. Associated symptoms. Mechanical symptoms, is there any clicking, snapping, catching, or locking like symptoms? Is generally seen in labral tear or loose bodies around the joint. Giving away feeling, does the leg feel like it collapses? Stiffness, is it difficult to put on the shoes or socks or get in and out of a car? Then T means timing, morning sickness. How long does it last? Brief stiffness less than 30 minutes suggests osteoarthritis. Prolonged stiffness more than 1 hour suggests inflammatory arthritis like rheumatoid arthritis. Night pain. Does it wake the patient from sleep? It can indicate severe osteoarthritis, malignancy, or infection. E from Socrates is exacerbating and relieving factors. We have to ask the patient, does weight bearing or walking make it worse or not? If it's worsening on walking, then it is intra-articular pathology. And does lying on that specific side make it worse? It is generally pointing out to trochanteric bursitis. Does rest relieve the pain or not? Then S stands for severity. On a scale of 0 to 10, ask the patient the intensity of pain that he is having. How does it affect his activities of daily living? Ask about their maximum walking distance and if they require walking aids like cane or walker. Next, we have to ask about past medical and surgical hip dysplasia, Perthes disease, or which predispose individuals to early arthritis. These have to be found out. And history of previous trauma, that is fractures or dislocations of the hip or pelvis. Systemic diseases, rheumatoid arthritis, ankylosing spondylosis, psoriasis, inflammatory bowel disease. Conditions predisposing to avascular necrosis, that is the sickle cell disease, systemic lupus erythematosus, and HIV. Any history of previous surgeries, any prior orthopedic surgeries or joint injections or spinal surgeries. Medications and allergies, usage of corticosteroids. Long-term or high-dose use is a major risk factor for avascular necrosis of the femoral head. Analgesic usage. What are they currently taking for pain, and is it effective or not? NSAIDs, acetaminophen, opioids, they have to be noted. Anticoagulants. It is important to note if planning for any injection or surgery. Allergies, note for any drug allergies. Family history of early onset osteoarthritis or joint replacements is important. Autoimmune or rheumatological conditions like rheumatoid arthritis and ankylosing spondylosis has to be checked, and congenital hip conditions have to be found out. Social and lifestyle history. Smoking impairs bone healing and is a risk factor for avascular necrosis and osteoporosis. Alcohol intake. Heavy use is a significant risk factor for avascular necrosis and falls. Activity level. Participation in high impact sports, distance running, or ballet. Increased risk of labral tears and stress fractures are there according to the activities. Living arrangements. Do they live alone? Are there any stairs in the house? This is critical for assessing their functional independence and post-operative planning if surgery is needed. Systemic review, we should look out for the red flags. Always screen for red flags that might indicate a serious underlying condition such as malignancy, infection, or fracture. Look for the constitutional symptoms like unexplained weight loss, fever, chills, or night sweats. Resting pain, unremitting pain that is present at rest and disrupts sleep. If there is any history of cancer, especially cancers that metastasize to bone, that is seen in breast cancer, prostate cancer, thyroid cancer, lung cancer, and kidney cancer. Neurological symptoms. Sudden onset of bowel and bladder incontinence or progressive saddle anesthesia is generally seen in cauda equina syndrome, requiring immediate emergency intervention, which is a red flag. Inability to bear weights. Sudden inability to bear weight after minor trauma in an older adult. It's highly suspicious of an occult hip fracture. Let's start with a general physical examination. This section assesses the patient's overall health status before focusing on the specific complaint. Let's start with the consciousness and orientation. Check if the patient is conscious, cooperative, and oriented to time, place, and person. Build and nutrition, if he is average built and well nourished or cachectic. Decubitus position in the bed. Generally, if the patient comes with pain, he is lying in supine, appears in obvious discomfort, and preferentially flexes the hip. Next, we have to check for pallor, best checked in the lower palpebral conjunctiva for anemia. Icterus checked in the superior sclera for jaundice. Cyanosis checked on the tongue, lips, and the nail beds. Clubbing checked for the loss of Shamroth window. Lymphadenopathy, especially checked the inguinal nodes for a hip case. And edema checked for the pedal edema over the medial malleolus. Vital signs, pulse has to be noted, rate, rhythm, volume, and character. Blood pressure, both sitting and supine position, diastolic and systolic pressures have to be noted. Respiratory rate and temperature if the patient is afebrile to touch. Systemic examination is done to screen the other systems to rule out complications or comorbidities. Respiratory system, look for normal vesicular breath sounds, any added sounds, generally the Krebs or V's. And cardiovascular system, check for S1, S2, and any other additional murmurs. Abdominal examination, it should be soft, non-tender, or if there is any organomegaly for hepato or splenomegaly. Important to rule out any psoas, abscess, or hernia. Central nervous system, check for any focal neurological deficits, tone, power, and reflexes in the lower limbs, which distinguishes the hip pain from the lumbar radiculopathy. Local examination. Following a detailed clinical history, the local examination of the hip joint is the next critical step. Because the hip is a deep joint, the examination relies heavily on assessing the gait, range of motion, and specific provocation tests. A standard orthopedic examination follows the sequence of look, feel, move, measure, and special tests. For a proper hip examination, the patient should ideally be exposed to their underwear to adequately visualize the pelvis, groin, and the lower limbs. Inspection. Skin for the scar, swelling and redness have to be looked. Pelvic tilt, leg length discrepancy, muscle atrophy, deformities, and gait has to be looked. Gait analysis, there are different types of gaits that have to be described. One is the antalgic gait. There is shortened stance phase on the affected size to minimize the weight bearing pain. It's generally painful hip osteoarthritis pathology or synovitis or trauma. Trendelenburg gait. In this gait, pelvis drops on the contralateral swing side during the stance phase. It's generally seen in gluteus medius weakness, nerve palsy. Coxalgic gait, it's a trunk shift towards the stance affected to reduce the abductor pull. It is generally seen in severe painful osteoarthritis and abductor inhibition. Waddling gait, it's bilateral Trendelenburg gait with exaggerated side-to-side trunk lurch. It is generally seen in developmental dysplasia of hip, myopathies, and bilateral osteoarthritis. So this is the normal gait, and this is an altalgic gait due to the hip pain. This is a coxalgic gait, and this is a Trendelenburg gait. Waddling gait, which is bilateral Trendelenburg gait. Next, we'll go with the palpation. We have to palpate systemically to identify areas of localized tenderness, warmth, or swelling. Anterior landmarks, we have to palpate the anterior superior iliac spine and the groin area, especially the inguinal ligament. Check for the inguinal lymphadenopathy or hernias, which can cause referred pain to the hip. Lateral landmarks, we have to palpate the greater trochanter. Point tenderness here is the hallmark of trochanteric bursitis or gluteal tendinopathy. Posterior landmarks, patient in the lateral decubitous position or prone position, we have to palpate the ischial tuberosity and the sacroiliac joint. Check for the range of motion. Flexion of the hip, which is 120 degrees is normal. Extension 10 to 20 degrees is normal. Abduction of hip 40 to 45 degrees is normal. Adduction 20 to 30 degrees is normal. Internal rotation 30 to 40 degrees is normal. External rotation 40 to 60 degrees is normal. If there is any early loss of internal rotation, there is a sign of classic osteoarthritis in that patient. Next, we have to check the measurements. Assess for leg length discrepancies, which can cause or exacerbate hip and back pain. Ensure the pelvis is square, that is anterior superior iliac spine level, and the legs are in the identical position. True leg length. Measure from the anterior superior iliac spine to the medial malleolus. The difference here indicates a structural shortening of the bone. For example, previous fracture or joint destruction causes this. Apparent leg length. Measure from the umbilicus or xiphisternum to the medial malleolus. The difference here with a normal true leg length indicates a functional shortening, generally seen with pelvic tilt due to a fixed adduction deformity. Neurological examination. We'll start with sensory testing, the dermatomes. Testing sensation over the hip and the thigh area. Common patterns include mapping the lateral femoral cutaneous nerve, that is the lateral side of the thigh, or L2, L3, L4 dermatomes for the signs of nerve numbness or tingling, that is seen in paresthesia. Manual muscle testing, look for the myotones, assessing the strength of the muscle groups around the hip. Flexion, it is L2, L3. Iliopsoas strength is assessed here. Extension L5, S1 and S2. Gluteus maximus strength is assessed here. Abduction L4, L5, S1. Gluteus medius or minimus strength is assessed here. Adduction L2, L3, L4. Adductor muscles are assessed here. Reflexes, testing deep tendon reflexes including the patellar reflex L3, L4 and the Achilles reflex S1. Neurological tests for nerve entrapment, meralgia paresthetica check, checking for the burning sensation over the outer thigh, and sciatic nerve assessment, checking for the radiating pain down the back of the leg. Key functional tests include the Trendelenburg test and the straight leg test. In Trendelenburg test, we have to evaluate the hip abductor strength, that is the gluteus medius strength, and the neural loop of proprioception. A positive test is where the pelvis drops on the opposite side, indicates the weakness of an L5 radiculopathy or neurological deficit. Straight leg raise, performed to detect nerve root irritation or radicular symptoms, which is generally seen in lumbar radiculopathy, which may mimic hip pathology. Let's start with special provocative tests. First test is the Trendelenburg test. Trendelenburg test is a physical examination technique used to assess the strength of the gluteus medius muscle and hip stability. Normal result is when Standing on one leg, a functional gluteus medius muscle contracts, causing the pelvis to lift on the opposite side. It is called abnormal. If the gluteus medius is weak, it cannot hold the pelvis level, causing the hip on the opposite side to drop. So significance of this test is it identifies hip instability, which can contribute to gait issues and chronic lower back pain or hip pain. Next is the Patrick's test or Faber test. Here the patient is in supine position. The hip and knee are flexed at 90 degrees. We have to stabilize the pelvis of the patient at the anterior superior iliac spine, and abduction is done on the affected side with figure of 4 in flexion, abduction, and external rotation. Anterior groin pain indicates hip joint pathology, osteoarthritis, or labral pathology. Posterior or buttock pain indicates SI joint involvement, often used to differentiate pain versus spine sources. Fadir test. Fadir is flexion, adduction, and internal rotation. This is a primary screening test for femoroacetabular impingement and labral tears, which is highly sensitive but less specific. Thomas test. The positioning is sit on the edge of a sturdy table or bed. Then lie back, keeping the buttocks right at the edge. Action is pull one knee towards your chest, holding it there tightly to flatten your lower back against the surface. Assessment. Keep the opposite leg relaxed and hanging off the head. Observation. Partner checks the testing leg hangs freely or lifts. Interpretation of the results. Normal flexibility. The thigh touches the table. Tight hip flexors, that is iliopsoas tightness. The thigh raises tight femoral, the quadriceps. Thigh is stable, but the knee extends significantly rather than hanging at the 90-degree raise to the composed with power. Tight tensor fascia lata or IT band hangs, but hip up Staheli test. Staheli test or method used to measure hip flexion contracture, extending the hip while the pelvis is stabilized. Thomas test because it naturally helps the lumbar. The examination gradually extends the patient's thighs, lifts it towards the ceiling. The test measures the horizontal thigh angle at the point where the pelvis begins to rise. Log roll test is highly specific for intra-articular or synovial. A passive detect here the patient is fine position, leg is kept fully relaxed, holding the ankle and gently rolling. Pathology. Increased pain and external rotation, ligament involvement. Indicates hip joint or iliopsoas is the straight leg to 30-degree. Log roll test. Log roll test, highly specific for intra-articular pain or synovitis. A passive rotational test for the hip joint used to detect the intra-articular pathology. Patient is in supine position, leg is kept fully relaxed, holding the ankle and gently rolling the leg. Here you have to do supine position. Now ask the patient to raise the straight leg up to 30 degrees hip flexion. Apply down resistance thigh. Patient tries to pull leg up against the resistance. Pain, if it is felt in the groin or anterior hip during the resistance, then it is intra-articular pathology, hip pain. More typical of joint pathology. Hip score or line test. Here, compression through the femur with rotating sweeps applies comprehensive forces to the articular cartilage and labrum. It is positive when there is any clicking, catching, or reproduction of pain. It is highly useful for assessing chondral defects or early osteoarthritis. Findings suggest if there is only pain, then it is joint pathology. If there is pain with clicking, then it is labral tear. If it is grinding, that means if there is any crepitus, then it is indication of osteoarthritis. And if there is no pain, it is likely extra arthritic. Test. A tube type it is commonly used in lateral hip pain.
Stop share. Share.
Ober test, a test used to assess tightness of the iliotibial band and tensor fascia lata. It is commonly used in lateral hip pain and IT band syndrome, greater trochanteric pain syndrome. Patient lies in lateral decubitus position with affected side up and unaffected side down. We should stabilize the pelvis and now flex lower hip or knee for stability. Upper leg, flex knee at 90 degrees and abduct and extend hip. Slowly allow leg to abduct passively. If the patient is unable to abduct, then it is positive. That means there is tightness in the IT band. Modified Ober test. Here the patient's positioning is the patient lies on their side on the unaffected side with the bottom knee and hip flexed for stability. The examiner stands behind the patient, stabilizing the pelvis with one hand on the upper iliac crest to prevent lumbar movement. The examiner lifts the top leg, extending the hip and extending the knee. While maintaining the knee extension and hip extension, the examiner allows the leg to slowly lower down adduction. Interpretation is negative test if the leg is able to adduct below the horizontal level. It is positive if the thigh remains in the abducted position, fails to drop with or causes pain during the drop. That is indicating there is tightness in the iliotibial band or tensor fascia lata. Differential diagnosis. Osteoarthritis, which is gradual in onset, worse with weight bearing and stiffness in the morning. Femoroacetabular impingement, which is common in younger adults, active adults. Pain during deep flexion or rotation is seen here. Trochanteric bursitis, sharp lateral pain Point tenderness over the greater trochanter is seen. Avascular necrosis, sudden onset, history of steroid usage or heavy alcohol consumption, referred lumbar pain, which is associated with back pain, numbness, or tingling radiating pain down the leg. Differential diagnosis based on the location of pain. If the pain is anterior, it can be osteoarthritis, labral tear, or femoroacetabular impingement. Here, the hallmark is limited internal rotation and deep dull ache. If the pain is on the lateral side of the thigh, then it is greater trochanteric pain syndrome. Here, the tenderness over trochanter or step down pain is seen. Posteriorly, if the pain is there, it can be SI joint or piriformis syndrome or lumbar radiculopathy. Here you can have positive straight leg test in lumbar radiculopathy or buttock tenderness if there is any piriformis syndrome. Anterolateral pathology, lateral side of the thigh is painful, then it can be due to meralgia paresthetica. Here the numbness or burning type of sensation is seen due to the lateral cutaneous nerve distribution in the lateral side of the thigh. Differentiating between intra-articular and extra-articular pain. So intra-articular is inside the joint, extra-articular is outside the joint. Pain location, primarily it is the groin or deep anterior hip in the intra-articular, lateral hip, buttocks or lower back in the extra-articular. Common sensation is deep dull ache or occasional sharp catching in the intra-articular, surface tenderness, burning or tightness in the extra-articular. On manual palpation, pain is deep. You cannot touch the source in intra-articular. Pain is often point tender and it is touched in the extra-articular. Movement triggers, squatting, putting on shoes or pivoting is very painful in the intra-articular. Climbing stairs, running or lying on your side is painful in the extra-articular. Mechanical signs like locking, clicking or feeling of instability is felt in the intra-articular. Snapping or popping is often felt in extra-articular, which is in the IT band. Typical diagnosis can be osteoarthritis, labral tear, femoroacetabular impingement in intra-articular, trochanteric bursitis, IT band syndrome, or tendinitis in the extra-articular. The C sign, which is commonly seen in hand cupped over the hip or joint in the intra-articular. Extra-articular, it is rare because patient usually points out with one finger to the side of the pain. Investigations, imaging modalities. First is the X-ray. Standard AP pelvis or lateral pelvis can be taken for osteoarthritis and femoroacetabular impingement. This image shows the osteoarthritis of hip joint. Here you can see joint space narrowing, osteophytes, and osteophyte of the femoral head. So this is an image of the X-ray of osteoarthritis. This image is for femoroacetabular impingement, where you can see asymmetrical femoral head attachment into the acetabulum. CT scan, because it offers superior bone detail, a CT scan is highly effective at identifying a variety of conditions, including the occult fractures, tiny or hidden breaks in the pelvis, femoral neck, or acetabulum, the hip joint, that might not show up on a regular X-ray. Arthritis, it is a degenerative joint disease, joint space narrowing, bony spurs, osteophytes, and bone cysts can be seen. Femoroacetabular impingement, a condition where the ball and socket of the hip joint rub together abnormally, causing friction and cartilage damage. Avascular necrosis, the early stages of the bone death caused by lack of blood supply of the femoral head. Tumors and cysts, benign or malignant growths within or around the bone. Infections, deep joint infections or inflammation in the surrounding tissues. This is an CT image of hip joint showing bone spurs and joint space narrowing, generally seen in the osteoarthritis. This is an image of CT scan of hip avascular necrosis, where you can see the avascularity in the hip joint. CT scan of femoroacetabular impingement, where CAM and pincer types. CAM type is the asymmetrical attachment of the femoral head into the acetabulum, whereas pincer type is the over coverage of the acetabulum onto the femoral head. Both the types can be seen in the FAI. MRI or MRA is the golden standard for visualizing the acetabular labrum. Labral tears are often seen in the anterior-superior quadrant. Paralabral cysts are strong indicator of a nearby labral defect. And clinical rule, You have to correlate imaging with physical examination tests like FADIR to avoid overdiagnosis. Pain interventions, intra-articular injection, diagnostic gold standard, which can be seen in 50% relief and confirmatory source. An intra-articular hip injection is a precise, often image-guided ultrasound or fluoroscopy procedure used to inject medication directly into the hip joint capsule. It serves diagnostic, that is confirmation of pain source, and therapeutic, reducing pain or inflammation from arthritis or injuries purposes, usually delivering relief about 3 to 6 months via corticosteroid and an anesthetic. Next is the PENG block, which is pericapsular nerve group block. The PENG block is a novel ultrasound guided regional anesthesia technique targeting the articular branches of the femoral, obturator, and accessory obturator nerves. The target is the anterior inferior iliac spine and the iliopubic eminence. Benefit is it is superior analgesic while sparing the motor function. Hip radiofrequency ablation technique. It is a minimally invasive outpatient procedure that uses heat to deactivate sensory nerves, the femoral or the obturator branches, supplying the hip joint, reducing the chronic pain. Here, the targeting nerves. The procedure targets the articular branches of the obturator nerve, femoral nerve, which are responsible for transmitting pain signals from the hip joint. Imaging guidance. The entire process is performed under fluoroscopy or live X-ray for precise needle placement. Patient positioning is patient is usually lies on their stomach, that is prone position, depending on the specific nerve target. Types of RFA, we have conventional RFA, which uses a monopolar probe to create a small focal lesion, and cooled RFA, it is a water cooled probe tip, keeps surrounding tissue at a manageable temperature while creating a larger, more effective lesion up to 80 to 85 degrees in the tissue to overcome an anatomical variability. Guided by fluoroscopy, a probe is placed near the hip capsule to create heat lesions, often used in cooled RFA technology to create larger, more effective burn zones, providing relief for up to 12 to 24 months. Targeted anatomy and approach. Femoral nerve branch. The electrode is often placed near the anterolateral margin of the hip joint, often just below the anterior inferior iliac spine. For obturator nerve branch, the needle is placed at the inferior aspect of the joint, often targeting the inferomedial joint space and the ischial or pubic ramus junction. Meralgia paresthetica injection involves an ultrasound-guided perineural infiltration of the lateral femoral cutaneous nerve near the anterosuperior iliac spines. The technique usually involves an in-plane lateral to medial approach to deliver 5 to 10 ml of anesthetic and corticosteroid into the fat pad, often using hydrodissection to separate the nerve from surrounding tissues. The probe is located on the anterior superior iliac spine and moved medially and caudally to find the lateral femoral cutaneous nerve as it passes through the fat pad between the tensor fascia lata and sartorius muscles. Anatomical targets. The nerve is often targeted just distal to the anterior superior iliac spine, where it passes under the inguinal ligament, which is the most common site of entrapment. Take-home message. Groin pain is reliable indicator of intra-articular hip disease until proven otherwise. Not all hip pain is hip pathology. Always rule out lumbar spine and SI joint sources. Early restriction of internal rotation is the first sign of hip osteoarthritis. Clinical examination is the cornerstone for special tests and guide diagnosis. Imaging supports but not replaces the clinical judgment. Diagnostic intra-articular injection is the gold standard for confirming the pain origin. Understanding nerve supply improves intervention success. Adopt a multimodal stepwise approach for accurate diagnosis and effective pain relief. Conclusion. Hip pain requires a systemic stepwise approach integrating anatomy, clinical examination, and imaging. A focused clinical assessment helps accurately identify the pain generator and distinguish intra-articular from extra-articular and referred causes. Modern pain management techniques such as the ultrasound guided injections, pen block, RFA have significantly improved both diagnostic precision and therapeutic outcomes. Ultimately, early diagnosis and targeted intervention are essential to reduce chronic disability and improve patient quality of life. I'm concluding with the references. I have taken the content from McLeod's, Algappan, Bonica's, and Das Clinical Examination. Thank you.
Okay, so that was an in detail explanation about the hip joint evaluation. Thank you all.